Very good. Good morning to all my dear friends who are joining through this YouTube channel. And today we are going to have a short test and discussion series in cardiology. I hope you all have listened to the cardiology lectures by Dr. Rashmi ma'am in the past few months. And we have almost have 12 to 15 lectures from ma'am covering various topics of the cardiology series. Today we are going to have a short test and discussion. This is a second test and discussion which we are conducting, and it will be covering almost all the points from the past few months topics, and it will have ECGs and everything. I hope that you have attended the test which was conducted from yesterday, and if not, kindly take the questions and now listen to ma'am so that you will have a wonderful session in identifying the pathologies in the ECG. Thank you so much, ma'am, for joining on this day of Independence Day.
Thank you, Sai. Thank you so much. So I'm very happy to be back with the cardiology test and discussion. We've had one more, like Dr. Raghu mentioned, we've had one more test and discussion earlier. So I have slightly increased the level of the questions so that these are the kind of questions that you can expect, whether it is NEET or in your day-to-day practice, as well as in USMLE or MRCP patterns. So what is the question might seem tough, but how you deduce the answer is most important. And I would like to tell you that the take-home point will be that the superficial reading is not sufficient. Okay, so we are dealing with lives every day, and we just can't afford to, miss even a single point in our study. Every single point is very, very important. It's not only about passing an examination, it's about dealing with patients. So superficial study is not sufficient. So we need to go into detail and learn each and every point correctly. There might be very small nuances that you must know, but each and every small nuance is very, very must. Okay, so I would like to start with the first question. I hope all of you have attended the Google Forms yesterday so that you will have an idea about what we are going to discuss today. Okay, yes. So 66-year-old lady with a past history of hypertension undergoes DC cardioversion for atrial fibrillation. Immediately following the procedure, transient ST elevation is seen. The patient is asymptomatic, but cardiac enzymes taken 12 hours later. These show a normal troponin I, but raised CK levels. The SHO calls you to advise him on the significance of the cardiac enzymes and the ECG findings. So what would you advise? So here is a patient with atrial fibrillation. She has a past history of hypertension. So atrial fibrillation, when do you give DC cardioversion? That is what we need to know, isn't it? So after the procedure, there's a small elevation ST segments and the patient is asymptomatic. The cardiac enzymes are also taken. And in that, you find that there's a normal troponin I levels, but the CK levels are elevated. So what does this mean? Okay, this is a very common scenario that you will identify in when you're posted in the emergency room, isn't it? So the first option is the ST elevation and raised CK are probably not abnormal. A raise in trop I but not trop T is sometimes seen following atrial fibrillation cardioversion. A rise in trop T but not trop I is sometimes seen following atrial fibrillation cardioversion. Both troponin I and T are usually raised post cardioversion. A raised CK suggests likely myocardial damage. Yes. So before we go into the answer for this question, we'll discuss how we manage atrial fibrillation. Okay. How do we manage atrial fibrillation? So a patient presents with atrial fibrillation. What is the first point that you see? Whether he's hemodynamically stable or unstable, right? Hemodynamically stable or unstable. How is the BP? How is the heart rate? How is his respiration? Is he hemodynamically stable or unstable? If he is unstable, then what do? You cardiovert the patient. Okay. What do? You resuscitate and synchronized cardioversion is given. Synchronized DC cardioversion is given. Okay. So if the patient is stable, what do? You try to see the time of symptom onset. You try to see the time of symptom onset. If the symptom onset is less than 48 hours or more than 48 hours. Okay. If the time is less than 48 hours, so what does it mean? You need to do rate or rhythm control has to be done. If it is less than 48 hours within 2 days, then you must do a rate or a rhythm control. Okay. If it is more than 48 hours, what you should do? You should try to control the rate. Rhythm control doesn't become mandatory here. You need to try to control the rate because fast heart rate has more bad effects. Okay, so you have to control the rate as well as anticoagulate the patient. What should you do? Anticoagulate the patient. Okay. So if the patient is stable hemodynamically, then you will see the time of symptom onset. If it is less than 48 hours, within 2 days, then you can do either rate or rhythm control. You have an option there. If it is more than 48 hours, you would prefer a rate control, and you also need to anticoagulate the patient. So how will you decide on anticoagulation? There comes the CHAD-VAS score. CHAD-VAS score. Okay. CHAD-VAS score. Based on that, you decide what anticoagulation you have to decide. Okay. So in this patient, the patient has undergone DC cardioversion. That means the patient was unstable at the time of presentation. Okay. So you give a shock to the patient. You cardiovert the patient. What happens at that time? There will be a mild ST segment elevation. Changes will be there. This is a normal finding. A normal ST elevation can be seen, which will be transient, and this is a normal finding. But what about the troponin I levels and the CK levels? The CK levels will tend to rise because there is some amount of skeletal damage also, skeletal muscle damage also. Okay. CK levels increase when there is a skeletal muscle damage as well. So when you cardiovert the patient, there might be some minimal skeletal muscle damage also occurring. So the patient can have raised CK levels, but there is no myocardial damage as such. So the troponin levels are not necessarily elevated. Okay. So the troponin levels are not necessarily elevated. So there is an ST segment elevation and the CK levels may be raised, but the troponin will be normal. So this is wrong. This is wrong. Troponin I and ET are usually not raised post cardioversion. Raised CK suggests not myocardial damage here. It denotes skeletal muscle damage. So the correct option will be the first option. The ST elevation and raised CK are probably not abnormal. Okay. So this question, first one, I have answered it for you. So the next question we will try to discuss. Okay. I want all of you to write your answers into the chat box so that we can have a discussion. Okay. This is a fairly easy question compared to the first one. Okay. A 65-year-old diabetic man with a previous history of myocardial infarction, for which no intervention was required, is found to have atrial fibrillation. His LVEF is 55% and has no cardiovascular symptoms. What would you advise him with regard to the best thromboprophylaxis? So how would you approach this question? I want all of you to write the answers in the chat box. Yes. So how would you approach this question? In the meantime, I would like to tell you some drugs. I want all of you to put the answers into the chat box. In the meantime, I'll tell you what are the drugs that you use for rate control as well as rhythm control. Rhythm control, I'm sure all of you will be aware. It will be amiodarone or flecainide. So for rate control, what would you use? Beta blockers will be the first choice, or diltiazem. Beta blockers, diltiazem, verapamil, and digoxin. All these 4 drugs. First line will be beta blockers to reduce the heart rate. The second will be diltiazem or verapamil based on the patient's condition. And the third one will be digoxin. Okay. This is for rate control. Rhythm control, you have 2 main drugs. First one is amiodarone. The second one is flecainide. Okay. And the other, how do you cardiovert? Otherwise, you use DC cardioversion. Okay. Pharmacological cardioversion is by amiodarone or flecainide. Electrical cardioversion is by DC synchronization. Okay. Yes. So what is the next one? How do you what is the answer for this? How do you approach this question? How do you approach this question? I'm not seeing any messages in the chat box, so I would like all of you to interact so that it will be a discussion and not just a one-way teaching. This is test and discussion, right? Yes. So how do you approach this? So mainly you have to, when the question about thromboprophylaxis comes in a patient with atrial fibrillation, what should you do? You should find out the CHAD-VAS score, isn't it? So you need to find out the CHAD-VAS score. So this is the score, right? So CHADSVAS. Okay. So what happens in this? There are, each point is given, each subheading is given 1 point, but there are 2 things which are given 2 points each. So that will be age and prior stroke. Okay, prior stroke and age will be given 2 points. So the first one will be C for congestive heart failure. H is for hypertension. A is for age more than 75 years. So you have 2 age criteria in this. Age more than 75 years gets 2 points, whereas age between 65 to 74 years gets only 1 point. Okay. And D is for diabetes mellitus. S is for prior stroke, TIA, or thromboembolism. Any of the clotting phenomena, if they have occurred, then it means that the risk is more. Then V for vascular disease. A is for age 65 to 74 years. S is for sex category. So female sex gets a score. Okay, male sex doesn't get a score. Female sex gets a score. Okay. So what happens in this patient? What are all the things? He is a male. So the age criteria, so the sex category criteria does not fit in. So what about the age 65 to 74 years? So that gets a 0.1, isn't it? That gets a 0.1. So what else he has? He has had a prior myocardial infarction, isn't it? So he has had a prior myocardial infarction and he is a diabetic man. He is a diabetic man. He's had a prior myocardial infarction. His EF is normal. Okay. So what is this? His Chadwas score comes to 3 points. So what does this 3 point mean? Okay. What does this 3 points mean? First, you need to know what is Chadwas score. The second thing you need to know how do you approach after coming to the Chadwas score? How do you approach the patient after you have known the Chadwas score? So if the patient is having a Chadwas score of 0, which means that the patient is at very low risk, how do you treat this patient? This patient, aspirin alone is sufficient. So it's enough if you give the patient aspirin alone. Okay. So if the patient is having a Chadwas score of 1, what would you do in this patient? The patient has a moderate risk. So the risk is moderate. What will you do? You will give aspirin plus warfarin. Aspirin plus warfarin. And you maintain a lower INR range. Okay. If the Chadwas score is greater than 2, greater than or equal to 2, then the risk is high. So what does this mean? You definitely need to anticoagulate the patient, preferably with warfarin or Dovax. Okay. Now the newer ones, newer anticoagulants or the Novax. Okay. Dovax or the Novax. So you need to anticoagulate the patient. You can choose between these based on the clinical profile of the patient. So if the score is more than 2, more than or equal to 2, what do you need to do? You need to anticoagulate the patient, preferably with warfarin or Novax. Okay, newer oral anticoagulants. So in this patient, what will you do? He's having a score of 3, isn't it? So what will you do for this patient? This patient, you definitely need to give warfarin. So you definitely need to give warfarin. So the answer for this question will be option 5, warfarin. Okay. Yes. Just a small highlight on what are the anticoagulants. So anticoagulants can be either parenteral or oral. Okay. So first we'll see what are the oral anticoagulants. The basic one is the vitamin K antagonist, which we normally used. This is warfarin or Coumadin. This is warfarin. Okay. This is a vitamin K antagonist. The second one will be thrombin inhibitors, direct thrombin inhibitors. Among that, it will be dabigatran, which we use very commonly nowadays. Dabigatran. The parental one we use very, very rarely, that is lepirudin. Lepirudin is used very rarely. So the direct thrombin inhibitor, which is dabigatran, is not used commonly. Okay. Then comes the factor 10A inhibitors, which is rivaroxaban. Okay. Rivaroxaban. In this, you have rivaroxaban, apixaban, and edoxaban. We very commonly use rivaroxaban and apixaban nowadays. Okay, in India. So factor 10A inhibitors will be rivaroxaban and apixaban. There's an easy way to remember. You have here XA, right? Here you have XA, that is 10A. 10A. In this, all these names as well, you have XA. This is a very easy way to remember. So direct 10A inhibitors will have XA in their names, rivaroxaban, apixaban, and edoxaban. These are all the oral anticoagulants. What about the parental anticoagulants? The first basic one, like the vitamin K, will have the unfractionated heparin, which we still use. Okay, unfractionated heparin. In the anti-factor 10A will be low molecular weight heparin. This also we use very commonly in patients waiting for surgery, immobilized patients in the hospital who are not yet walking. So in these patients, we use enoxaparin very, very commonly, then dalteparin and tinzaparin. The other one is if the patient is having, hit antibodies, or he has heparin-induced thrombocytopenia. In those patients, the preferable one will be fondaparinux. Okay. The preferable one will be fondaparinux. So this is a very, very high yielding question. Based on this one question, you need to learn so many things, isn't it? So that's the way you will be able to, reinforce the topics that you have learned earlier, and also trying integrating the topics and studying in one place. This may be a pharmacology question, but definitely this is based on medicine. Okay, so pharmacology and medicine go hand in hand. So you definitely need to remember the oral anticoagulants. How do you approach the CHA2DS2-VASc score? And once you get the score, how do you actually anticoagulate the patient? Okay. Yes. So in all the questions, you will have some concept which is important that you need to remember. So I have concentrated on the most important concepts that you need to learn very, very thoroughly. Okay. So which of the following is true of an atherosclerotic plaque formation? So let me read the options. It is an acute inflammatory disease of the vascular intima. It is characterized by accumulation and modification of cholesterol esters on the luminal surface of the endothelium. Macrophages bind and phagocytose oxidized LDL to form foam cells. Typical form away from the branch points. Endothelial dysfunction as a result of an insult to the endothelium is characterized by increased nitric oxide release. Increased nitric oxide release. So which is the answer for this? Yes, I would like all of you to interact in the chat box. So what is the answer for this question? Which of the following is true for atherosclerotic plaque formation? So I have a figure here so that you can remember easily. Photographic memory is also very, very important. So I would like all of you to remember this image. Okay. So what happens first? What is the first point which will happen? What is the initiation factor for atherosclerosis? So you have some risk factors. What are the risk factors? Risk factors are those which cause, which predispose the patient to developing atherosclerosis. So what are those? Hyperlipidemias, hypertension, so dyslipidemias, then hypertension, okay, diabetes mellitus, then procoagulant states. All these predispose the patient to develop atherosclerosis. Okay, so the patient should have a risk factor to develop atherosclerosis. Then what happens? There will be an endothelial dysfunction. Okay, what happens because of the risk factors? There is an endothelial dysfunction. What happens when the endothelial dysfunction is there? There will be an expression of the adhesion molecules. What are the adhesion molecules? PCAM, all those adhesion molecules have been expressed. So what happens at that point of time? What happens when the adhesion molecules are expressed? So there are macrophages in the endothelium, isn't it? There are macrophages inside the vessel. What will happen? These will ingest the lipids. These will ingest the lipids and they will go into the intima media space, the space between the intima and the media, they will go there. Okay. What happens? These macrophages will actually engulf the lipids and form foam cells. What do they form? They form foam cells. How are the foam cells formed? Macrophages engulf the lipids and actually convert them into foam cells. Okay. These foam cells, what do? They grow into the intima media space. They go into the media and the vascular smooth muscle proliferation occurs. There is a transformation and they become thicker. That location becomes thicker. Then on top of that, because of all these factors, calcification happens because there is inflammation. So because of that, there is a plaque and there is a coating on that. There is a layer on that which was very, very tough. And if the tough layer ruptures, then what happens? There is a lipid core and there's a tough layer. When the tough layer ruptures, what happens? The clot formation will be there. This will cause ischemia. Okay, this will cause ischemia. We have studied this in brief in the ischemic heart disease chapter when we are discussing about the pathology of ischemia. So we need to remember how atherosclerosis happens. How does it happen? First, the patient is having risk factors like dyslipidemia, hypertension, diabetes, some procoagulant states, etc. And they are predisposed to endothelial dysfunction. When the endothelial dysfunction happens, what happens? The adhesion molecules are expressed. Because of the adhesion molecules, what happens? All the macrophages come into that location. When the macrophages come there, they actually engulf the lipids. And what do? They form foam cells. They engulf the lipids and form foam cells. They mature and they come and lie in the media. Once they come to the media, they undergo some transformation, the smooth muscles proliferate, and what happens later on? A plaque is formed. Okay, what happens? A plaque is formed. Okay, when the plaque is formed, what happens? There is a lipid core, and on top of that, there is a tough layer. When the tough layer is exposed because of some reason, when there is a rupture of the tough layer, what happens? A clot formation happens, and there is ischemia. A clot formation happens, and there is ischemia. Okay, so this is the pathogenesis behind atherosclerosis. So coming to this question, so what is the answer for this? Macrophages bind and phagocytose oxidized LDL to form foam cells. So this will be the answer for this question. I would like you to remember this endothelial dysfunction. Actually, what does it do? What does endothelial dysfunction do? What does it do? So when there is actually a nitric oxide release, the increased nitric oxide is actually anti-atherogenic. Okay, anti-atherogenic. So what does this mean? When there is an endothelial dysfunction, the nitric oxide levels are reduced. Because of the decrease in the nitric oxide levels, there is more propensity to develop atheromas. Okay, so increased nitric oxide means there is anti-atherogenic. So decreased nitric oxide means there is an increased propensity to develop atheromas. Okay, and the branch points. Atherosclerosis always favors branch points. Atherosclerosis actually always favors branch points. They are not away from the branch points. They are favoring the branch points. Okay, so this is very, very important. This pathology you would have learned in your second year, but you need to recollect it here and you need to remember it always. Okay, because pathology, if you remember the pathology only, you can understand what are the drugs used and where they act. So based on that only you can treat the patient. So all these are interlinked. It is not like this question is from pathology, this question is from pharmacology. It's not like that. You need to understand the pathology behind each and everything. Then you will be able to answer very, very easily. Okay. Okay. Let's move on to the next question. So a 38-year-old IV drug abuser presents with a history of malaise and rigors since 1 week. His temperature on admission was 38.5 degrees Celsius. Examination revealed a significant pansystolic murmur, which was loudest at the left sternal border. 3 sets of blood cultures were taken. The transthoracic echocardiogram showed vegetation of the tricuspid valve with moderate tricuspid regurgitation. Which of the following organisms is most likely to be positive in blood cultures? So, what is the answer for this question? So, how would you approach this question? So, this is an IV drug abuser, which is the most important point in this question, right? IV drug abuser is a very, very important point in this question because the organism depends on that. We all very well know this is what we are discussing is on infective endocarditis, right? We are discussing on infective endocarditis. So we need to remember what organism is more common in certain special situations, right? So in this condition of IV drug abuser, which option will be the correct one? This is a very basic question. I would like all of you to answer. Yes. So before we come to the answer, what we'll do is we'll discuss something about, we'll just recollect something about infective endocarditis. We have a detailed chapter on this. I've taken it earlier also, but just to reinforce and, reiterate here, we'll just have a small discussion on infective endocarditis. Yeah. So infective endocarditis. What is the diagnostic criteria called? It's called modified Duke's criteria. Modified Duke's criteria, right? So what does this have? This has major as well as minor criteria. Major as well as minor criteria, right? So what are the major and minor criteria? So if there is an usual organism, if it's streptococcus or staphylococcus, some organism that you expect to, or an enterococcus that you expect to actually produce endocarditis, if the culture should be positive for that, then it comes under the major criteria. Okay, blood culture is positive for infective endocarditis. Then there should be an evidence of endocardial involvement. Also, there is one more point which says there should be evidence of Coxiella burnetii. Okay, there should be a single positive culture of Coxiella burnetii, or there should be an increase in the Ig immunoglobulin titers more than 1 in 800 for this Coxiella burnetii. This also comes under the major criteria. So blood culture positive for infective endocarditis, evidence of endocardial involvement, coxiella burnetii, culture identifying coxiella burnetii, or there's an increase in immunoglobulin titers of more than 1 in 800 positive for coxiella burnetii, then all these come under major criteria. So what is the minor criteria? The patient should have a predisposing cardiac lesion, say an artificial heart valve. Artificial heart valve. Okay, or immunosuppressed patients. Immunosuppressed patients, or they're having a valve lesion like AMS, MR, or AR, or MS. They're all, predisposing factors. Then the temperature should be high. They should be having a fever. Then they should have also some vascular phenomena. They should have vascular phenomena and immunologic phenomena. So what are the vascular phenomena which you should remember? Named ones, D.N.B lesions. You should not confuse between the vascular phenomena and the immunologic phenomena. So vascular phenomena will be something like D.N.B lesions, but the immunologic phenomena will be painful nodes. Painful nodes. You must remember Osler's nodes. Osler's nodes, which are painful. And what else? Rot spots. Rot spots on the retina. All these are important. Okay, so D.N.B lesions, Osler's nodes, rot spots, these are all important. You must also remember Osler's nodes are painful. And you must have some microbiological evidence. There is positive culture, which are not involving the major organisms. Some minor organisms which are not definitely found to be associated with major criteria. Then those organisms you have to have a microbiologic evidence. So you now know the major and the minor criteria. So when do you have a definitive diagnosis of endocarditis? When there are 2 major criteria, or 1 major and 3 minor criteria, or just all the 5 minor criteria. Okay, you need to have both the major criteria, 2 major criteria, or you must have all the 5 minor criteria. You need to remember easily 2 major criteria or all the 5 minor criteria. Combining both, 1 major, 3 minor. Okay, this means that there is a definitive diagnosis of infective endocarditis. When will you say that there is a possible diagnosis of infective endocarditis? There is only 1 positive criteria, 1 major criteria, and 1 minor criteria. Okay, in that case, you say that there is a possible infective endocarditis, or the patient has any 3 of the minor criteria, say fever, vascular phenomena, and microbiologic evidence. Okay, so in this case, this means that there is a possible diagnosis of infective endocarditis. Definitive diagnosis, 2 major criteria, 5 minor criteria, or 1 major, 2 minor criteria, 3 minor criteria. Okay, for the possible diagnosis, you need to have 1 major and 1 minor criteria, or 3 minor criteria. Okay, this is very, very important to remember. Okay, so let us see about some special situations, what you must remember. So I'll just write it out. You will find out what is the organism. So what is the infective endocarditis most common organism in neonates? For IV drug abusers, then prosthetic valve endocarditis, and in colon cancer. These are very, very possible MCQs. These are very high yield questions also. So you need to remember what are the most common organisms in neonates, IV drug abusers, prosthetic valves, and in colon cancer. So the first one, in neonates, it will be Staph aureus. Okay. In IV drug abusers, if it is a right-sided valve, it will be most commonly Staph aureus. This is the most common also. But if it is left-sided, there is a possibility for Enterococcus. Okay, there is a possibility for Enterococcus. Okay, or Pseudomonas. Enterococcus or Pseudomonas. You must remember this, Enterococcus or Pseudomonas. And prosthetic valve, which is more common, if it is less than 2 months after the prosthetic valve, implantation, then it will be CONS, coagulase negative organisms. So it will be CONS. If it is more than 2 months, then it is more common Strep viridans. It is like any other valve. Okay, so it will be most common Strep viridans. In colon cancer, you need to remember the most common organism is Streptococcus bovis. So in neonates, Staph aureus, IV drug abusers, if its right side is involved more, it will be Staph aureus. If the left is involved more, Enterococcus or Pseudomonas. Prosthetic valve, less than 2 months, CONS, more than 2 months, Streptococcus viridans. If the patient is having a colon cancer, the most common organism will be Streptococcus bovis. Okay, Streptococcus bovis. So in this patient, what do you find? He is an IV drug abuser, and he has an infective endocarditis on the right side. That's the tricuspid valve, right side. So the most common organism in this patient will be Staphylococcus aureus. Staph aureus will be the most common organism involved. Okay. So while we are touching about this topic on infective endocarditis, there is one more question where you will get very, very commonly asked about is prophylaxis. When do you actually give the patient prophylaxis? So this is very common complicated question. They will ask you that the patient is going for a dental procedure. He has the prosthetic valve. Should you actually give the patient prophylaxis or not? So when will you give the patient infective endocarditis prophylaxis? It is indicated when the patient has had a prior history of endocarditis, when the cardiac valve disease in a transplanted heart, when the patient has undergone a heart transplantation and is having a requirement for an endocarditis prophylaxis, then you should definitely give the patient prophylaxis. If there is an unrepaired cyanotic congenital heart disease or an incompletely repaired cyanotic heart disease, then you give the patient prophylaxis. Then congenital heart disease repaired using a prosthetic material. If there is a prosthesis for any reason in the heart, say it be it a cardiac transplant or a heart disease repaired through a prosthetic material, say like grafts or a prosthetic heart valve. Shunts, we remember we have discussed in PDA, so that, or a prosthetic heart valve because of regurgitation or severe stenosis. In those patients, you have a prosthetic heart valve, or if you have a valve repair using a material prosthetic, and if there is any prosthetic, then you should definitely give prophylaxis for the patient. Okay, you should definitely give prophylaxis for the patient. The common things where it will be confusing is if there is an atrial septal defect or there's hypertrophic cardiomyopathy or a mitral valve collapse with regurgitation. For all those things, you don't need to actually give prophylaxis for the patient. Okay, so this is a very, very high yield slide that I would like all of you to remember. Infective endocarditis is very favorite topic for the examiners for them to question you on. Okay. Yes. So moving on to the fifth question. Moving on to the fifth question. A 51-year-old farmer with low-grade fever and a recent history of weight loss. He has been investigated by GP and general physicians, but no cause has been identified for his symptoms. His inflammatory markers are raised, and a transthoracic echocardiogram shows a 0.5 by 0.3 centimeters echogenic mass attached to the non-coronary cusp of the aortic valve. Endocarditis is suspected, although multiple blood cultures are negative. Which of the following organisms is the most likely cause of persistent negative cultures? Persistent negative cultures. So this is another important topic in the infective endocarditis. When do you get these persistent negative cultures? So the most common of which you must remember is the Hackett group. Okay, HACEK. Okay, Hackett group. This is very, very important, which is Haemophilus, then aggregative factor, cardiobacterium, E is Eikenella, and K is Kingella. Okay, all these organisms, they don't have positive cultures, but they're very, very notorious to cause infective endocarditis. Okay, another important thing that you must also remember is Coxiella burnetii. Coxiella burnetii. Very rarely, it is not very commonly, it is not isolated in the cultures, but in these patients, you definitely need to use the IgG titers. Okay, you need to use the immunoglobulin titers. If the immunoglobulin titers are elevated, then that means that the patient can have patient can have infective endocarditis. So Hackett group and Coxiella burnetii are two very, very important things that you must remember for a persistently culture negative infective endocarditis. Okay. So which of the organisms are most likely cause of persistently negative cultures? So in this, you must remember Cardiobacterium hominis and Coxiella burnetii. These are very, very important. Coagulase negative staphylococci, we have seen it is most common in less than 2 months after the installation of a prosthetic heart valve, infective endocarditis. Okay. So Cardiobacterium hominis and Coxiella burnetii, these are two important organisms which cause persistently negative cultures. Okay. Next, moving on. The sixth question. An 8-year-old woman is admitted with acute pulmonary edema on a background of progressive shortness of breath with exertional chest pain for 6 months. Okay, acute pulmonary edema, 8-year-old lady with progressive shortness of breath and exertional chest pain for 6 months. She's initially commenced on IV furosemide with good effect. An echo reveals 40% with severe aortic stenosis and estimated valve area of 0.7 centimeter square. So what would you do next? So this patient is having an aortic stenosis with an estimated valve area of 0.7 centimeter square. So what does this mean? This means that the patient is having very severe aortic stenosis because it is less than 0.8 centimeter square. Okay, the valve area is less than 0.8 centimeter square. So that means that the patient is having very severe aortic stenosis. So what would you do next? Would you add a beta blocker? Would you perform angiography with a view to the aortic valve replacement or transcatheter aortic valve implantation? Will you do that? Or add an AC inhibitor or implant a defibrillator? Or will you do both A and B? Will you add a beta blocker as well as perform the angiography? Which of the answer is correct? Yes. So this is an old lady with very severe aortic stenosis. So which answer is correct? So I would like all of you to interact. So which answer is correct in this question? So let us discuss something about aortic stenosis. Yes, just recollect. So less than 0.8 centimeter square, that means it is a very severe aortic stenosis, right? So angina symptoms, what are they? Exertional dyspnea, exertional angina, and exertional syncope. These are the three main symptoms. What is the pathology, main pathology behind the symptoms in aortic stenosis? Behind all the things that happen in aortic stenosis, that is left ventricular hypertrophy. That is very, very important. Okay. How will the pulse be? Pulses powers at tardis. It will be slow rising and late peaking. Pulses powers at tardis. It will be a very, very low volume pulse, and the pulse pressure will be less. Okay. And the left, because of the left ventricular hypertrophy, you will have a left ventricular heaving apex. And what are the murmurs that you will have? You will have an ejection systolic murmur in the aortic area. Ejection systolic murmur in the aortic area. The A2 will be delayed. There will be a narrow splitting or a reverse splitting will be there because of the delay in the A2. Okay. And because of less blood in the left ventricle, because of left blood in the left ventricle, the aortic valve will be delayed. I mean, aortic A2 sound will be delayed and the P2 will occur earlier. So because of that, a reverse splitting can be seen. Okay. When will you do? How do you manage a patient with severe aortic stenosis? What will you do? You need to see if the patient is symptomatic. So what will you do? If the patient is asymptomatic, then you will actually follow up the patient. Follow up if asymptomatic, isn't it? If the patient is having symptoms, then what do you do? Symptoms are there. So when do you take up the patient for surgery? If the patient is, first of all, if the patient is undergoing CABG for some other reason, if the patient is having an ischemic heart disease and he needs to undergo an emergency CABG, at that time itself you do the aortic valve replacement also. Okay. And if the EF is less than 50%, if the ejection fraction is less than 50%, if the patient is going into failure, that means then you have to do the aortic valve replacement. Then if the symptoms are more, okay, and if there is a decrease in BP on exercising, if there is a decrease in BP on exercising, then you do the aortic valve replacement. Okay. And if there is a rapid progression of symptoms, this is the easy way to remember that big flow chart. Okay. Rapid progression of symptoms, then you will actually do the aortic valve replacement. Aortic valve replacement, it can be either surgical or transcatheter approach. Okay. So in this patient, what will you do? This is an old patient with very severe aortic stenosis. Definitely you must operate because she is symptomatic. Okay. Progressive shortness of breath, exertional dyspnea and exertional angina is both are there. And the EF is also less than 50%. So what will you do? You need to push this patient for an angiography, right? And you also need to add a beta blocker because the patient will have symptomatic relief. Okay. The chest pain will be reduced. So angina symptoms will be reduced if you add a beta blocker. So for this patient, the correct answer will be option 5. You need to do both angiography as well as add a beta blocker. Okay. You need to do both the things, right? Yes. So let's move on now. The next question. A 42-year-old Caucasian woman presents to the OP when she's 10 weeks pregnant with her second baby. Her first pregnancy was complicated by peripartum cardiomyopathy with moderate impairment of left ventricular ejection fraction. However, she did not have complete resolution of systolic function 6 months after the birth of her first child. Which one of the following statements is true? So what is this? The patient, a 42-year-old lady, she has come to the OP. She is now 10 weeks pregnant with a second baby. Her first pregnancy, she had peripartum cardiomyopathy, which actually had moderate impairment in left ventricular ejection fraction. She completely had resolution of the symptoms after that, within the 6 months after the birth of her child. Which of the following statements is true? So before we go into the options, we'll discuss something a little bit about peripartum cardiomyopathy. I have not discussed it in the previous topic, so I have just mentioned it in the previous chapters, but I would like to discuss some points in detail which you must remember for your MCQs. Okay, so what is peripartum cardiomyopathy? How do you actually define peripartum cardiomyopathy? First, let us define peripartum cardiomyopathy. Peripartum cardiomyopathy. How would you define that? So, it is something that happens, it's a cardiomyopathy which happens towards the end of pregnancy, or within 5 to 6 months post-delivery. 5 to 6 months post-delivery. Okay, it can happen either during pregnancy or immediately after delivery. So when this happens, it's called peripartum cardiomyopathy. So what happens in these patients? The ejection fraction will be less than 45%. The ejection fraction will be less. Okay. And what else will they have? When do you suspect the patient's age will be more than 30 years? The patient's age will be more than 30 years. The risk factors are the patient will have more age, the age of pregnancy will be more, gestational age will be more. Then they may have some other comorbidities like an existing heart issue, or they can have multiple pregnancies. Okay, so if it's a twin or a triplet pregnancies, or even 4 quadruplets, which is now very common because of this in vitro fertilization. Okay, multiple pregnancies. Okay, then diabetes mellitus, then cocaine abuse in the mother. All these are very, very important risk factors for a patient to develop cardiomyopathy. Okay, the other risk factors which will be preeclampsia and eclampsia, all hypertension, all these are very, very important. Diabetes, all these, even communicable diseases which happen in the pregnant mother are also contributing to peripartum cardiomyopathy. So how do we define it? Peripartum cardiomyopathy is cardiomyopathy happening towards the end of pregnancy or between 5 to 6 months post-delivery. The ejection fraction will be reduced less than 45%. And the risk factors include patients more than 30 years of age, multiple pregnancies, the patient having diabetes mellitus, preeclampsia, eclampsia, then maternal cocaine abuse. All these are very, very important, risk factors. So what actually happens in these patients? In whom is it most common? It is most common first in Africans. Africans is most common. Second will be Asians. Asians, it is also common. So Africans, it is most common. It is very, very characteristically seen in Africans. In Asians, it is second most common. Okay. Yes. So there is some hormonal changes, some vascular changes will happen, which contribute to the patient developing peripartum cardiomyopathy. What are these? These are hormonal changes, the involvement of the RAS system, then also including some vascular changes which happen, which contribute to the development of peripartum cardiomyopathy. Okay, so what happens? How do you treat this patient with cardiomyopathy? All of you know the treatment will be the same. So for acute cases, what do you do? Treatment for acute cases, you give the patient oxygen, you give symptomatic relief, you give mechanical ventilatory support if the patient requires ventilation, mechanical ventilator support. And the drug that you must remember in this patient is bromocriptine. Yes, bromocriptine. Bromocriptine. So bromocriptine is used in the treatment of acute peripartum cardiomyopathy. Peripartum cardiomyopathy, bromocriptine is very, very important. This can be an MCQ question. So how do you treat chronic peripartum cardiomyopathy? How do you treat? So you use RAS blockers. What do you use? RAS blockers, then beta blockers. RAS blockers, beta blockers, etc. Okay. And you may also need a cardioverter defibrillator in these patients if they are having rhythm abnormalities also. So, and they actually predisposed to rhythm abnormality. So you might actually need a implantable cardioverter defibrillator. Okay. So RAS blockers and beta blockers are very, very important. So I would like, including all this, you must also know about the prognosis, because most of the questions and the question that we have also discussed is based on the prognosis in these patients. How do you prognosticate the patient? So a patient comes to you and asks you, what is the risk of me developing peripartum cardiomyopathy next pregnancy also? What will you answer? So for that, you need to know about the prognosis, right? So how do you define the prognosis? This prognosis is generally good in all the patients. They actually have complete resolution of symptoms. Like in this question also, the first time around, she actually had a complete resolution of her symptoms, right? So the prognosis is good. Okay. So what happens? In this, almost 50% recover completely. The 50% will recover completely. Then 20% among that will have relapses. 20% will have relapse of peripartum cardiomyopathy. This is very, very important. 20% will have a relapse. 50% will have completely cured, will be completely cured, whereas 20% will have a relapse. Okay. 25% will have persistent symptoms. Okay. They will not have been completely cured, but they will have persistent symptoms. Okay. They will have persistent symptoms. And 25% will develop complications. They will not be able to come out of the ventilator. They may have arrhythmias. Okay. So they may go into development, they may go into complications. Or less than 10% will have mortality. Okay. Less than 10% is the mortality. So it is very, very less. Just around 3% will be the mortality. So this is very, very important. The prognosis is very good. 50% almost have complete resolution of symptoms and 20% will relapse. Okay. So in this question, so what are the options? A risk of death during pregnancy significantly increased. No, we saw that the prognosis is good. The mortality is very, very less. A risk of developing heart failure during pregnancy is around 20%. Okay, we'll come to this option. If she develops cardiomyopathy during this pregnancy, the likelihood of resolution of LV function after pregnancy is high. Yes, because it's a recurrent episode, the resolution of symptoms may not be complete. Okay, so this is also not correct. Prophylactic use of ACE inhibitors is mandatory. We cannot prophylactically use because ACE inhibitors are contraindicated in pregnancy, right? So in pregnancy, you cannot use it. Post-delivery, you can probably use it, but in pregnancy, you cannot use. So prophylactic use of ACE inhibitors is not recommended. Early detection of heart failure by clinical examination during the pregnancy will be sufficiently sensitive to detect deteriorating LV function. So during a pregnancy alone will not be sufficient. You need to have a watch out in the postpartum period also. Okay, after the delivery of the baby also you need to be cautious. So it is not only during pregnancy. So the correct option will be a risk of developing heart failure during this pregnancy is 20%. Why is this? Why do we say about this golden number 20%? I told you that is the relapse rate. Relapse rate. So you remember, it's because her first pregnancy she had a peripartum cardiomyopathy. This is the second time around, and so she has a relapse of around 20%. So this is the answer for this question. Okay. Yes. You have been referred, moving on to the next question. You've been referred a 65-year-old man whose clinic BP recordings have been persistently around 151 and 90 millimeters mercury. But he claims to suffer from white coat phenomenon. He says, I come to you and I'm getting tense, that's why my BP is high. But his home recordings are around 135 by 90 millimeters mercury, which you are satisfied have been taken appropriately. He's otherwise healthy, having implemented dietary changes and increased his exercise over the last year. But he smokes and intends to continue. So what would you recommend to this patient? Will you recommend that a clinic recording, which if normal, suggests no need for medical management, and if more than 140/90 requires treatment? A 24-hour ambulatory blood pressure monitor is needed. Salt restriction, exercise, and continued home monitoring. Commencement of pharmacological treatment. Home devices are not as reliable as a mercury sphygmomanometer. Therefore, the clinic measurement should be believed and treatment should be commenced. So, what are we talking about in this patient? We are talking about diagnosing hypertension in this patient, right? So, we are now talking about how we diagnose the patient. What are the numbers we base it on, right? So, a patient is having 150 or 90, right? This is already an indication to start medical management. If it is more than 140/90, you start the patient on pharmacologic treatment. Okay. And I have already told you home recordings or ambulatory blood pressure recordings of more than 135 by 85 millimeters mercury. We have this in our class discussion. So if it is more than 135 by 85 millimeters mercury, then you should definitely start the patient on pharmacological treatment, because at home they tend to be a lot more relaxed, a lot more calmer. So the BP tends to be a little bit lower, around 5 to 10 millimeters mercury less than the office recordings. So this is very, very reliable. Okay. So 135 by 85 millimeters mercury. If it is more than that, then you start the patient on pharmacologic treatment. But anyway, what is the first thing that needs to be done? Lifestyle modification, right? So first thing that needs to be done is lifestyle modification, which the patient has started doing. He has implemented dietary changes, and he's also increasing his exercise over the last year. So he has been doing some lifestyle modifications. So in this patient, what would you do? You should actually start the pharmacologic treatment. Okay. You should start the pharmacologic treatment for this patient. Okay. Yes. So what are the modifications that you will reduce? First is weight reduction. then you should have a DASH diet. There should be some dietary sodium restriction of less than 6 grams of sodium chloride. Then physical activity is a must. Physical activity is most important, and alcohol consumption should be reduced. Okay, these are all the lifestyle modifications that we recommend to the patient. What are the drugs that we use? The first line drug is now AC inhibitors or ARBs. The second line will be calcium channel blockers, right? And the third line will be a diuretic. Beta blockers in special cases. When you use beta blockers, when the patient is having already existing some cardiac issue, then you will have the patient if is having LV failure, then you will give beta blockers. Okay, so the first line drug will be AC inhibitors. Okay. Which one of the following factors would you worry about a patient with pulmonary arterial hypertension? Yes. A 6-minute walk distance more than 380 meters, static symptoms, MVO2 of less than 12 ml per minute per kg, normal BNP levels or right atrial pressure is less than 10 millimeters mercury. So which one of the following factors would you worry about a patient with pulmonary arterial hypertension? Yes. Any answers for this? I would like those of you who have attempted the Google form, I would like all of you to give the answers so we can discuss here. If you have any doubts also, you can clarify at this moment. So we'll see something about pulmonary artery hypertension. Okay, so pulmonary hypertension has 5 stages. Okay, five types of pulmonary hypertension are there. Among that, the first one is pulmonary arterial hypertension. So pulmonary hypertension has 5 types. Among that, the first one will be pulmonary arterial hypertension. Okay, the second one will be pulmonary hypertension due to left heart disease. Third one will be pulmonary hypertension due to lung disease, chronic lung disease. Like the patient is having COPD, then he develops cor pulmonale, right? That is pulmonary hypertension type 3. Okay. Then fourth one, pulmonary hypertension due to thromboembolic disease. Thromboembolic disease. So the patient is having a pulmonary embolism, chronic pulmonary embolism, and the patient is developing pulmonary hypertension. So that is pulmonary hypertension type 4. And type 5 will be miscellaneous causes. Okay. So this is not very important. You must remember that the first one is pulmonary arterial hypertension. So how do you define pulmonary arterial hypertension? How do you define that? Pulmonary arterial hypertension is defined as the mean pulmonary arterial pressure. Pulmonary arterial pressure should be more than 25 millimeters mercury. The mean pulmonary artery pressure should be more than 25 millimeters mercury. But the capillary wedge pressure, the pulmonary capillary wedge pressure should be less than 15 millimeters mercury. That is when you define pulmonary arterial hypertension. The pulmonary artery pressure should be more and the pulmonary capillary wedge pressure should be less. Okay. That is when you diagnose pulmonary arterial hypertension. It's just only at the arteries. It has not yet transferred into the venous system. Okay. So that's why the PCWP will be lesser. So only this is purely pulmonary arterial hypertension. The pulmonary artery pressure is elevated. It is more than 25 millimeters mercury, whereas the capillary wedge pressure is lesser. It is less than 15 millimeters mercury. Okay. This is when you diagnose pulmonary arterial hypertension. So how do the patients present? They will have dyspnea. They can also have chest pain and they will have syncope. Dyspnea, chest pain, syncope. These are the most 3 characteristic findings, of which dyspnea is the most common. Okay. So how does it progresses very rapidly in many cases. And what is the most common cause of death? This is a very important MCQ. What is the most common cause of death? Decompensated heart failure. Okay. Decompensated heart failure is the most common cause of death in these patients. Decompensated heart failure is the most common cause of death in these patients. You must remember this, decompensated heart failure. Which heart failure? Right heart failure. Right heart failure is the most important common cause of death in these patients. So pulmonary hypertension, you have seen the types and you also seen the definition and the most common cause of death. So this is very important. It's very, very commonly asked in your MCQs. Okay. Yes. So what is the screening test for these patients? Screening test will be echo. This will be the screening test. So what is the gold standard test? What is the gold standard test? You will actually go inside and measure the pressures, right? What is the gold standard test? Catheterization and measuring the hemodynamics there. So invasive hemodynamic monitoring, invasive hemodynamic monitoring is the gold standard test, right? Invasive hemodynamic monitoring is the gold standard test. Okay. Invasive hemodynamic monitoring is the gold standard test. This is very, very important. So coming to this question, what do you find here? What do you find? What do you think will be the answer? The 6-minute walk distance will be reduced because of the difficulty in breathing. The patient will have a significantly lesser 6-minute walk distance. Static symptoms. This will be progressing very fast. Okay. So this will be progressing very, very fast. So this is also not correct. BNP levels will be elevated because the right heart is failing. So this option is also wrong. So because the right heart is failing, you will have elevated BNP levels. The right atrial pressure will be more because this pressure is transmitted to the right side. The right atrial pressure will also be more. It will not be less than 10 millimeters mercury. So the answer will be MVO2 less than 12 ml per minute per kg. Okay. So how do you actually prognosticate these patients? Based on what do you prognosticate the patient? So 6-minute walk test should be less than 380 meters. They should have if they have rapid progression of symptoms, if they have elevated BNP levels, if the right atrial pressure is more than 10 millimeters mercury, and if the patient is having a pericardial effusion, also if the MVO2, which is the peak oxygen consumption, will be more than 12 ml per minute per kg. All these means the patient will have a bad prognosis. Okay, the patient is having some evidence of right ventricular failure. If the 6-minute walk distance is less than 380 meters, if the patient is having rapid progression of symptoms, if there are BNP levels are elevated, if the right atrial pressure is more than 10 millimeters mercury, if the peak oxygen consumption is more than 12 ml, and if there's a pericardial effusion, all these means that the prognosis is bad. Okay, all these means that the prognosis is bad. So how do you treat pulmonary hypertension? I want all of you to complete pulmonary hypertension here itself. You must understand the pathology behind this. Okay. So how do you treat? The first drug that we all know, sildenafil. Sildenafil, what is it? It's a phosphodiesterase inhibitor, PDE5 inhibitor. So PDE5 inhibitor, phosphodiesterase inhibitor, what will it do? It will increase the cyclic GMP levels. What will it do? It will increase the cyclic GMP levels. Right? So sildenafil, it's a phosphodiesterase inhibitor. It will increase the cyclic GMP levels. Okay. So what about the next drug that we used? Endothelin receptor antagonist. Endothelin receptor antagonist. In that you have bosentan, atrasentan, and macitentan. Okay. You must remember most common bosentan. You must definitely remember. Bosentan is very, very important. You must remember that. Even if you forget the other two, it's all right. But you need to remember bosentan. Sildenafil, bosentan. And one more thing that they can ask you as an MCQ is, which is the drug which is inhaled and used? Inhaled will be iloprost. What is the drug? Iloprost. So inhaled drug will be iloprost. Okay. So this you must remember. This can ask as a one-liner in your MCQ. Iloprost is the drug which is inhaled and is used in the treatment of pulmonary arterial hypertension. Okay. Yes. You're reviewing a 42-year-old man in the outpatient clinic. He has had 16 episodes of pericarditis, which was always following a viral illness. There is no underlying systemic cause, despite investigations. The episodes are associated with small to moderate sized pericardial effusions. Initially, the episodes respond well to systemic steroids. However, he has had troublesome steroid side effects. On weaning the steroids with appropriate colchicine cover, the episodes recur. What is the best option with regard to the management? So what is this? This patient is having severe steroid withdrawal. He is steroid dependent. So he is having steroid withdrawal. Okay. Steroid withdrawal. On withdrawing the steroids, he precipitates a episode of pericarditis. Okay. And this is idiopathic pericarditis. This is not infective. This is idiopathic pericarditis. Okay. That's why it's happening so many times in spite of treatment with steroids. So this is idiopathic pericarditis and he's having a severe steroid withdrawal. So what will you do for this patient if they're having so many episodes of pericardial effusion? What will you do? You cannot continue steroids forever because steroids are very, very harmful. Okay. And you have to convert it and give it into a some colchicine, or you need to add some other drug. But you need that even on having the patient, even on putting the patient on colchicine, the episodes still recur, right? So what does it mean? Steroids are not working, colchicine is also not working. So what would you do when this patient is having such multiple episodes? You will definitely have to consider the patient for total pericardiectomy. Okay, you have to consider the patient for total pericardiectomy. That is what you need to do for these patients. So the answer for this question will be option 4. You need to refer this patient to a cardiothoracic surgeon for consideration of total pericardiectomy. Okay, because this is refractory pericarditis, refractory steroid-dependent idiopathic pericarditis. So you need to do a total pericardiectomy for this patient. Okay, yes. This question is very, very easy. Which of the following drug mechanism of these actions is mechanism of action is true? Ezetimibe, cholesterol absorption inhibitor, simvastatin, bile acid sequestrant, cholestyramine, agonist of PPAR alpha, then nicotinic acid, interstellar cholesterol binder, gem fibrosol, HMG-CoAs reductase inhibitor. So let's come from back. What is gem fibrosol? What is gem fibrosol? So in the name you see it is a fibro. So it is a fibrate. What does it do? It is a fibrate. What does it do? It is a PPAR alpha agonist. It is a PPAR alpha agonist. So thereby it reduces the cholesterol levels. What about nicotinic acid? Nicotinic acid actually causes lipolysis in the adipocytes. It decreases lipolysis in the adipocytes. Okay, decreases lipolysis in the adipocytes. Okay, so it's not that, right? Yes. What is cholestyramine? What is cholestyramine? It is a bile acid sequestrant. It's a bile acid sequestrant, right? It's a bile acid sequestrant. So this mechanism of action is not correct. This is not correct. This is not correct. What is simvastatin? Statins are HMG-CoA reductase inhibitors. HMG-CoA reductase inhibitors. HMG-CoA reductase inhibitors. So this is also not correct. So what is this option? Ezetimibe. Ezetimibe is definitely a cholesterol absorption inhibitor. So what is the benefit of this ezetimibe? It does not inhibit what fat dependent vitamins, fat soluble vitamins, fat soluble vitamin absorption. Okay, fat soluble vitamin absorption. So that is the most important point of ezetimibe. It inhibits the absorption of cholesterol, but it does not inhibit the fat soluble vitamin absorption. So vitamin deficiencies will not be that much with these patients. So ezetimibe, which is a cholesterol absorption inhibitor, is the correct answer for this question. Right? Yes. So we now move on to the spotter ECGs, the most interesting part of this discussion. So here, a 35-year-old man presents with palpitations. He has been drinking heavily with his friends over the weekend. This is his ECG. So what would you say based on this ECG? Yes. So what do you see here? The heart rate is definitely more than 100. Heart rate is definitely more than 100 per minute. Is it regular? It is not regular. So it is irregular. So what comes to your mind when you say irregular? It could be atrial fibrillation. So now look at the P waves. Do you actually find P waves? Do you find any P waves? No, P waves are not seen. You can see here the P waves are not seen. Yes. So it is atrial fibrillation. Atrial fibrillation. So given this history of binge drinking, what would you say? You need to remember something called the holiday heart syndrome. Holiday heart syndrome. When does this happen? A person binging on alcohol and he develops atrial fibrillation. So that is called holiday heart syndrome. So this is a ACG, characteristic ECG of atrial fibrillation. It is irregular, and the heart rate is more than 100 per minute. Okay. Yes. So this is atrial fibrillation. This is holiday heart syndrome. The patient is having a binge drinking and he develops atrial fibrillation. Okay. So these are all spotters. I want to discuss it faster. Okay. A 75-year-old man with a history of COPD presents with fever and increased sputum production. So there's some issue with the lungs and he's having an ECG abnormality. So how do you approach this ECG? So in this, what do you think about the heart rate? It is definitely more than 100, right? Heart rate is more than 100, which means tachycardia is there. So heart rate is definitely more than 100. Is it regular or irregular? So you can see it is irregular. So coming on to the P wave morphologies. Is the P wave same in all? You need to remember, in atrial fibrillation, we saw that there were no P waves. Here we will see that there are different morphologies of P waves. You see here, There's a different morphology of P waves. Here the P wave is inverted, here it's upright, it is big. Yes, here again it is inverted. So here you can see like this, you can see a smaller P wave. Here you can see it is joining with this. So the morphologies of P waves are different. So what do you call this? Polymorphic atrial tachycardia. What is it? It is polymorphic atrial tachycardia, right? So this is not atrial fibrillation. Because of the different morphologies in the P wave, it is polymorphic atrial tachycardia, right? So this is a very important spotter ECG. Yes, moving on to the next one. A 65-year-old man is found unresponsive with no central pulse or respiratory effort. So the patient has gone into cardiac arrest, right? There is no central pulse, but you take his ECG, you do find some electrical activities there. So you can find some electrical activities there, definitely. But the patient is not having any pulse. So what is this called? Electrical activity is present. Electrical activity is present, but no pulse. So what is this called? This is pulseless electrical activity, or PEA, pulseless electrical activity. That is PEA. So when the patient is having PEA, what do you do immediately for the patient? You need to start CPR as per ACLS protocol. You need to start CPR. Okay. You need to definitely start CPR. There are some reversible causes of pulseless electrical activity which you should remember, which is cardiac tamponade and tension pneumothorax. If these two are corrected, then this pulseless electrical cardiac activity will be abating. So you need to look for these two reversible causes importantly: cardiac tamponade, whether there is a cardiac tamponade, or whether there is a tension pneumothorax. If these two are excluded, and then you start the patient on CPR, and can you shock it? Can you shock pulseless electrical activity? Can you shock pulseless electrical activity? No. The answer is definite no. You cannot shock pulseless electrical activity. So what are the shockable rhythms? I want to revise here itself. What are the shockable rhythms? There are two shockable rhythms. Shockable rhythms. What are they? First one will be ventricular fibrillation. Ventricular fibrillation. The first one will be ventricular fibrillation. And the second one is pulseless VT. Second one is pulseless ventricular tachycardia. You cannot shock pulseless electrical activity, but you can shock pulseless ventricular tachycardia. So the two shockable rhythms are ventricular fibrillation and pulseless VT. Okay. So this is an pulseless electrical activity. Yes. So coming on to this ECG, I want you to find out what this is. I have not given any history because this is basically a spotter ECG. You need to find out just by looking at it. So how will you approach this? There is, of course, tachycardia is there. Tachycardia is there, which means the heart rate is more than 100 or 150. The heart rate is more, right? Yes. And are they regular? Are they regular? Yes, we can see that they are regular, right? They are regular. Yes. What about the QRS? So far, we've all seen narrow QRS, right? Here you can see that the QRS is quite wide. The QRS is wide, right? QRS is wide. So we are now discussing about wide QRS tachycardia, right? Wide QRS tachycardia. Then you must recollect what are the wide QRS tachycardias. Among that, which one is this? So P wave is not basically visible in this patient, in this ECG. So what is it? Ventricular tachycardia. This is ventricular tachycardia. Okay. This is ventricular tachycardia, right? So if the patient is having no pulse, if he's pulseless, will you shock? Yes, we need to shock the patient. If the patient is pulseless, then you definitely shock the patient. You start CPR and you also give shock. Right? If the patient is having pulse and if he's hemodynamically stable, you can actually give medications to control the ventricular tachycardia. It depends on the patient whether the patient is having pulse or not. So assessment of pulse in between CPR is very important. Okay, so this is a shockable rhythm and you should be able to shock and actually revert the patient. So ventricular tachycardia. Fine. Yes. We're coming to the end. A 58-year-old man has come to the ER with chest pain. He loses consciousness while his ECG is being recorded. So as his ECG is being recorded, he's losing consciousness. He has no central pulse and is taking occasional deep breaths. So he's going to cardiac arrest. He's gone into cardiac arrest while taking the ECG. Okay. He's come to you with chest pain. So what happens initially? The heart rate is lesser, say around 100 per minute. Yeah, say around heart rate is around 100 per minute. Okay, 100 per minute. Then here it actually increases, right? Heart rate maybe around 300 per minute. Heart rate increases to around 300 per minute, right? Here you see they are wide complexes, right? They are wide complexes. Okay. And what you see here, there is an ST elevation. Sorry, what do you see here? In 2-3 AVF, in 2-3 AVF, you have 2-3, and also AVF, you have ST elevation. Ventricular fibrillation. Ventricular fibrillation. You can see here ventricular fibrillation. Yes, you can see here. This is like, up and down. This is ventricular fibrillation. The P waves are all not discernible at all. So the inferior wall MI, the patient is having ongoing inferior wall MI, which is actually disintegrating and going into a ventricular fibrillation. The patient has gone into arrest. You definitely need to start the patient on CPR and shock the patient. Right? You need to give shock for the patient because ventricular fibrillation is a shockable rhythm. So we have now seen ECGs of MI, heart rate abnormalities, wide QRS as well as narrow QRS, and atrial arrhythmias. Okay. So I have discussed some of the spotter ECGs. I've tried to cover all the topics which have been included so far in the cardiology discussion. Okay. I hope you find all this useful. We'll come back with another chapter soon. Okay. Thank you so much for joining in.
Thank you, ma'am. Today we have almost 15 students have attended. So the test, and Spruha Joshi from Grant Medical College, Mumbai, has scored almost 30 marks, and 3 ECGs are correct, and few case discussion also correct, ma'am. And second place goes to Kaushik. He has scored 24, ma'am.
Okay, very good.
Scored good.
Congratulations, all of you. I hope this, this discussion will be more useful. In whichever questions you have not been able to answer correctly, you can go back. Superficial reading will not be sufficient. You need to go into the depth so that you will be able to manage patients better. Okay. Thank you.
Kaushik is from MMC. Kaushik is from MMC, and Spruha Joshi is from Grant Medical College.
Very nice.
The test will be open. You can just attend the test, and after completing the test, if those who have not yet completed, you can attend the test, and again you can see the videos. We are in the important topics are also like splitted and divided, and again it is re-uploaded while the session is going on. So you can see that video also if you want to see the individual discussions of each question. Thank you so much, ma'am, for joining with us today. And I hope we will go with the next section of the medicine soon. Thank you, ma'am.